Now testicular tumors. Testicular tumors can be classified into 5 types. 5. Basic 3 types. Germ cell tumor, sex cord stromal tumor, and others. Germ cell tumor includes seminomatous and non-seminomatous. Seminomatous include seminoma and spermatocytic seminoma. Non-seminomatous include yolk sac tumors, choriocarcinoma, teratoma, and embryonal carcinoma. Yolk sac tumor is otherwise called as endodermal sinus tumor. Now comes sex cord stromal tumors. They include Sertoli cell and Leydig cell tumor. Others are testicular lymphoma, and metastasis. For this classification, let's go to the risk factors. Risk factors may be due to family history, genetic predisposition, due to chromosome 12p, isochromosome 12p, that is actually 2p, and testicular dysgenesis. It may be due to cryptorchidism, or Klinefelter. And chemicals, pesticides. Then comes precursor lesion. Precursor lesion involves intratubular germ cell neoplasia or germ cell neoplasia in situ. This is the now used term. Germ cell neoplasia in situ. But this is not a precursor in teratoma and spermatocytic seminoma. Now to differentiate between the invasive and the non-invasive lesions, we use PAS stain. Fast stains the basement membrane, which shows whether it is invaded or not. Now the risk factors over, precursor lesions are over, we go to the clinical presentation and investigations. Clinical presentation involves painless enlargement of the testis. Now investigations include FNAC or biopsy. We need to look at it. FNAC is contraindicated in testicular tumors, whereas biopsy is used. Even in biopsy, there are true cut biopsy and excisional biopsy, in which excisional biopsy is used for tumors, true cut is not used for tumors. So where are they used? They are used in infertility workup. Now consider there is a metastasis to the inguinal lymph nodes. There FNAC can be done, and when the FNAC is looked under the microscope, histopathological examination gives tigroid background. And this is particularly for germ cell tumors. Now fixatives used. For tumor and for infertility. For tumor we use 10% formalin, that is neutral buffered formalin. For infertility, Bowen's fluid. It is yellow in color due to the presence of picric acid. And it is used because it preserves the morphology of the germ cells and helps to locate the arrest of the cells. And neutral buffered formalin is not used because it destroys cells. Now going on to individual tumors. First, let us differentiate between seminomatous and non-seminomatous. Seminomatous tumors occurs in young people, 20 to 30 years. This occurs in the elderly. Involves lymphatic metastasis, hematogenous metastasis. Good prognosis, poor prognosis. Radiosensitive, radioresistant, but chemosensitive. Now, seminomatous tumors include seminoma and spermatocytic seminoma. Features: occurs mostly in adults 20 to 30 years, young adults, and there is a painless enlargement, good prognosis, lymphatic metastasis, and radiosensitive. This is basically what we had already seen. Leave it off. Going on to the markers. Markers are PLAP positive, HCG positive, LDH positive. Alpha fetoprotein will never be positive. OC34. No, here we go with the mnemonics 1, 2, 3, and 4. CD117 positive 1, D240 positive 2, OCT34 positive 3 and 4, SAL4 positive 4, nano. This is 5. These are the markers. These are the new markers. Gross. Cut potato appearance. No hemorrhage, no necrosis, and homogeneous white structure. Histopathological examination shows cells in nest. Fried egg appearance. Now comes spermatocytic seminoma, which has features occurs in elderly, and ITGCN, which is nothing but germ cell neoplasia in situ more commonly now. They are not the precursor for spermatocytic seminoma. It has an excellent prognosis and there is no metastasis. No metastasis and excellent prognosis. Now histopathological examination shows 3 types of cells: small, medium, and giant cells. There are 3 types of spermatocytes with spirine chromatin. With this, seminomatous tumors is over. Now coming to non-seminomatous tumors, we have yolk sac tumor, choriocarcinoma, teratoma, and embryonal carcinoma. Going with the 4 types of non-seminomatous tumor: yolk sac tumor, otherwise called as endodermal sinus tumor, choriocarcinoma, teratoma, embryonal carcinoma. Yolk sac tumor mostly occurs in children less than 4 years. Gross appearance shows variegated appearance. That is, it has got necrosis, hemorrhage, cyst, and solid. Microscopy. Microscopy shows Schiller dual body or glomerular body. glomeruloid, and cords or tubules arranged cells, then eosinophilic hyaline globules. Immunohistochemistry shows alpha fetoprotein positive, alpha 1 antitrypsin positive. Alpha fetoprotein is positive in yolk sac tumor, hepatocellular carcinoma, and hepatoblastoma. Acellular dual bodies are also seen in here. Yolk sac tumor it is seen, also seen in glioblastoma multiforme. With this we move on to choriocarcinoma. Choriocarcinoma is seen in elderly. It is an aggressive tumor. It has poor prognosis. It is radioresistant but chemosensitive and has cannonball metastasis in the lungs. Now on gross there is hemorrhage and necrosis. On microscopy we see cytotrophoblast, which is uninucleate, syncytiotrophoblast, which is multinucleate and looks like giant cells, and hemorrhagic areas. On immunohistochemistry shows beta HCG positivity. Now comes testicular teratoma. Features are it has more than 2 germ layers, and when it forms cyst it is dermoid. Gross shows skin, hair, nail, bone, teeth, etc. Types. There are 2 types. They are mature and immature. So mature form is benign, which is pre-pubertal. This is post-pubertal. Mature, immature, benign, malignant. Embryonal carcinoma is a diagnosis of exclusion. Occurs in mid-age to elderly. And on histopathological examination we see papilloid configuration and primitive cells. And immunohistochemistry shows CD30 positivity and cytokeratin positive. The other places we see CD30 positivity are the current topic embryonal carcinoma, also Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma in which Reed-Sternberg cells, and non-Hodgkin lymphoma, anaplastic large cell lymphoma, and primary effusion lymphoma. With this, non-seminomatous tumors are over. Now moving on to sex-caused stromal tumors, which is Sertoli cell tumor and Leydig cell tumor. Sertoli cell tumor is silent, and immunohistochemical marker is inhibin. Leydig cell tumors occurs in the middle age to elderly. Hormones produced are androgen and estrogen. Gross shows gold pigmentation due to lipofuscin. Histopathological examination shows small cells, eosinophilic cytoplasm, and increased Ranke's crystals. Clinical features are gynecomastia, masculinization, and precocious puberty. And the sex-caused tumors are over. Moving to testicular lymphoma. The features are it occurs in elderly, more than 60 years, and involves, that is D, 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 and D. Sorry, B, body look elderly. DLBCL, diffuse large B cell lymphoma, so B, and it has a bad prognosis, so B, and it is bilateral, it affects bilaterally, so B. With this, testicular tumors are over.